Welcome to Be Well. This is Jonathan from the YMCA. Thank you for joining us today. Our topic is significant, noting a report I saw recently from Medical News. It spoke of 1 in 2 women and 1 in 3 men in the US will develop cancer in their lifetime. So our focus today, our topic is get your screenings, the importance of cancer prevention during this COVID period. February is Cancer Prevention and Screening Awareness Month. And we are very fortunate today to have a panel of experts in areas of cancer prevention, screening, treatment, and they will also be able to speak to the latest approaches to pursue during this period of COVID. This truly is an opportunity to understand the progress that's been made against cancer, the risk factors in developing, as well as survival rates. So my hope is that you use the chat to offer questions and comments. But we are very fortunate to have an expert panel with us. And I will share just a quick introduction to each of them. And we're going to go through looking at and speaking to each doctor on their specialty. And then we'll have an opportunity at the very end as a panel to discuss. But throughout, please offer your questions and comments. We're fortunate to have Dr. Jyoti Mayadev, Professor, Assistant Vice Chair, Developmental Therapeutics, Gynecological Oncology, oversees all clinical, translational research aspects of image-guided brachytherapy for gynecological cancers. That was a lot for me to be able to bring through without my medical background. So Dr. Mayadev, I'll give you a moment to kind of share, but I'm going to introduce the other guest this morning. We have Dr. Peter Vu. Peter is also a medical oncologist specializing in the treatment of gastrointestinal cancers using chemotherapy, targeted therapy, novel immunotherapies, and cellular therapy. So I believe we're going to have a wonderful opportunity to understand that in much greater depth. And then our last panelist is Dr. Angelique Richardson, is a board certified medical oncologist specializing in the diagnosis, treatment in breast cancer. She uses chemotherapy, hormone therapy, targeted therapies. Her research involves looking at the cancer health disparities and survival rates related to certain types of cancer, certain types of breast cancer. So that is the qualification, so to speak, of this expert panel that we'll have to spend some time with. So with no further ado, I want to introduce Dr. Jyoti Mayadev to speak to the particular area of cervical cancer. So Dr. Mayadev, welcome. Thank you for being with us today.
Well, thank you so much, Jonathan. And thank you to really the YMCA community for joining today. And, like Jonathan said, we are very interested in talking today about screening. And most of my work and research and clinic focuses in on cervical cancer. And so we'll talk about prevention and screening for cervical cancer, and then answer any questions, I think, towards the end.
Great.
So in general, I'm just going to minimize this. Cervical cancer continues to be a threat throughout the globe. And there's more than 500,000 new cases of cervical cancer diagnosed every year, with more than 300,000 deaths. Now, a lot of these cases are actually in the developing world. But in the United States, we have about 13,000 new cases per year. And unfortunately, 1/3 of patients will continue to die of their disease. And the rates of HPV-associated cancer, that's human papillomavirus-associated cancer, continues to rise in the United States. You can see in this graph here, in blue, are the cases of cervical cancer. The average age is actually 49 years old. Vulvar cancer, anal cancer, oropharyngeal cancer that tends to affect males and predominantly white males, middle-aged, as well as vaginal cancers. And this is a case that we often see, unfortunately, of a patient who has a very large cervical cancer, you can see here in the arrows, that causes pain and bleeding and a lot of suffering. So how can we potentially prevent this as a medical community? Well, the diagnosis of cervical cancer is really made once there's a lesion or a high-risk lesion seen on the cervix. Here you can see this is the uterus, the fallopian tubes, and the ovaries. And often a doctor will put in a speculum in order to see the cervix. And cervical cancer is very unique in the sense that there are precursors to cervical cancer. So there's often an abnormality of cells that are seen. This is often picked up on something called the Pap smear. And we'll talk about the screening on the Pap smear. But usually there's something called low-grade changes, then high-grade changes, and then it progresses to cervical cancer. The diagnosis of cervical cancer from this kind of abnormal cells to cervical cancer can be different for various patients, but it can really be anywhere from up 5 to 20 years. So what is HPV? And we all hear about it, but the human papillomavirus is the most sexually transmitted disease and virus throughout the world. It causes virtually all cases of cervical cancer, but these new acquired HPV infections are usually cleared. It's just persistent HPV infections that lead to cervical cancer and other cancers. And unfortunately, right now, we don't know which patients or who in the community will have this persistent HPV longevity. So the diagnosis of cervical cancer really comes down to HPV exposure. How do you get HPV? And what if I had the vaccine? And should I get the vaccine? We'll talk all about that today in the next couple of minutes. And the majority of cervical cancer, more than 80%, we've actually showed this in our research studies, are from HPV 16 and 18, which are two common types of HPV. But the HPV vaccine is more than 98% effective in decreasing the risk of this HPV causing cervical cancer. So HPV vaccination reduces cervical precancers that then decreases the risk of invasive cancer. In the United States, after the HPV vaccination program took place, we have seen dramatic decreases in the number of high-grade lesions in the United States. And over time, that will also translate to decreased cervical cancer rates. This has been shown, say, over the globe, as well as in Europe and in Australia. The HPV vaccination is safe, effective, and it provides long-lasting protection. So the HPV vaccine is safe, it works, and it lasts. The HPV vaccine actually covers for females all of these cancers that are caused by HPV: cervix, anal cancer, vulvar cancer, oropharyngeal, head and neck cancer, or vaginal cancer. And for men, head and neck cancer being predominant type, anal cancer, or even penile cancers. With the HPV vaccine, we can prevent more than 30,000 new cancers every year. It was licensed in the United States by the FDA in 2006. So now we have a lot of time where patients have, and children, teenagers have received this vaccine, and it's shown that it has been safe. Currently, the recommendations are focused on immunization for both males and females. But I wanted to spend a little bit of time talking about women, ages between 27 and 45. These women during this time frame can be given the HPV catch-up vaccine in the sense that often insurances will pay for it. You can give the HPV vaccine even at 9 years of age. The American Academy of Pediatrics recommends HPV vaccination between 9 and 12 years of age, along with the American Cancer Society. Essentially, it's important to give the HPV vaccine before sexual exposure. So that's when it will be most effective. Another way after prevention, which is ideal, so we want to prevent HPV before it causes the cancer through the vaccine, is using the Pap smear. It's the most successful cancer screening technique in all of medicine. It was first produced in 1928 by Dr. Pap. And it has significantly decreased substantially the number of cervical cancer cases in the United States, almost cut in half since 1975. So in terms of when should you get the Pap smear, if you're between 20 and 29 years old, you can start getting Pap tests at age 21. If one Pap test is normal, then you can get another Pap in 3 years. If you're between 30 and 65, you have options. You can get a Pap test alone, or or you can get something called an HPV co-test. If your HPV co-test is negative for the high-risk HPV types that cause cervical cancer, then you can wait up to 5 years before another pap smear. And these are all somewhat, evolving. But I think the main take home today is to try to encourage, children, adolescents in your community to get the HPV vaccine, and then encourage women after 21 throughout their lives to be screened regularly with the pap smear. And that's all I have. Thank you so much.
So Dr. Mayadev, when you started your presentation, really got my attention that we're seeing a rise in infections. And this is at a time where we're bringing the best of air, greater research, HPV testing, pap smears is more prolific, I would think. So I'm curious why we're seeing that rise when there's therapies that are going to show a reduction.
Yeah, and in the United States, we continue to see overall a decreasing trend for cervical cancer based on the HPV program that was initiated after 2006. But globally, we continue to see a rise in cervical cancer. Interestingly enough, though, Jonathan, we have seen an uptake in HPV-related oropharyngeal cancers. That means head and neck cancer. And it could be that before we were just diagnosing them later in life or detections, but it all goes back to the fact that the HPV vaccine is available both for adolescent young women and men. Early when the HPV vaccine was first adopted by the FDA, it was to target cervical cancer. But now we've seen that, well, there's HPV cancers that are prolific in the head and neck as well. And so we really want to target this as an anti-cancer vaccine for both our young children of both sexes.
That's excellent information. How long has the HPV been available?
It was FDA approved, the HPV vaccine, in 2006. So at this point, we have a lot of data, decade-long data, to suggest that it's very safe and very effective.
I remember as a parent, so when my daughter was, I think, about 11, that was a discussion as a family whether she would have the HPV. And I remember back then, and this is going back maybe 15 years or so, it seemed to be more of a question versus some of the therapies, it's perfunctory, makes sense, do it. And so what is the receptivity to HPV at this point in terms of really our community embracing this as a mechanism, as a method to avoid cancer?
Yeah, I mean, Jonathan, oh my goodness, we could probably spend hours on this, but in general, in summary, I think the community is starting to recognize that this is, an anti-cancer vaccine. It's very safe, it's very effective. Giving this vaccine to children has shown to be safe and will translate throughout their lives in terms of decreasing cancer burden. So that's really, with the National Cancer Institute, the American Cancer Society, the American Society of Pediatrics have studied this extensively. So we want to make sure that the community knows this is safe.
And I appreciate you highlighting that because I'm aware that there's often a lot of medical information out there. And so that's why it's so important to have a voice like yourselves come forward and share that. Anything unique in terms of this COVID area of the last 2 years and how that may have impacted people staying current with vaccines, embracing the vaccinations?
Yeah, well, during COVID, it's been difficult on all of the community, as well as, the healthcare providers. We have seen that the vaccination rates have gone down. Screening rates and vaccination rates have gone down because I think people were a little bit worried about, going to the hospital or their clinics. But we want to let people know that now that the COVID, we know how to take care of the COVID strategy, the vaccination has worked also in COVID, that I think it's kind of, allowing the community to see that vaccines are a major, major prevention in medicine. And that, yes, all of us work at Moore's Cancer Center, but the best medicine is prevention. And I know that you focus a lot about that at the YMCA.
Most definitely. And I'm going to pause there. I think that's a powerful statement in terms of the best method being prevention. So I appreciate that. Dr. Mayadev, we'll come back to you in a little bit, but thank you very much for what you've shared.
Thank you so much, and thanks to the audience for being here.
Thank you. So Dr. Peter Vu, let's, if we will, thank you for being with us as well. And let me give you the opportunity to share about colorectal cancer prevention and what's happening in this particular area.
Great. Thank you so much for the invitation. I'm so glad to be able to speak to everyone here. All right. So can you see my slides?
Yes, thank you.
Perfect. All right. So I'm going to talk specifically about colorectal cancer screening and prevention. And so let's get right to it. So just so that we all know what we're talking about, the GI tract is kind of a big area. And so the colon kind of starts over here and it kind of wraps around. This is the ascending, transverse, and descending. And then it goes into the rectum and then the anus. And so that's really what we're referencing when we're talking about colon and rectal cancers. And, you know, I kind of see it as like a pipe or a tube. And a lot of times you get the initial growths of these first polyps in this layer. And then as things progress, then they kind of grow out in both sides, and you'll see here. So here you can see kind of an early lesion that shows up on the inside of the colon. And so when you take a look using a camera through here, you can usually see them as polyps initially. And then as time progresses and this lesion, if it becomes cancerous, then you can kind of see it get larger and kind of invade through. And then this little picture here on the right shows that we kind of have a good understanding about how cancer progresses, at least how colorectal cancers progress. And it's through a number of different mutations. Some of them, for some people, they're born with certain susceptibility genes or mutations that predispose them either to the development of polyps or to cancer. And then some of the things that we may just acquire during our lifespan. And then, so it's kind of this long progression that you go through from kind of a normal cell to a polyp to then being something with cancer. And so patients, you know, there's a huge variety of symptoms that patients may have. So some actually complain of bleeding. A lot of times in our younger patients, they usually say that, you know, they were seeing their primary care doctor or they weren't seeing their primary care doctor, but they noticed a little bit of blood in their stool. And they thought, you know, the most common thing is they thought it was hemorrhoids or something like that. And so they decided to kind of wait and just kind of ignore it. But bleeding is definitely a concerning sign for something that we should look further into. Sometimes you could just have red blood in the stool, or depending on the location of where the issue is, you could have dark or black colored stool. Also, sometimes a change in the shape of your stool could be another sign. Some patients have this lower abdominal cramping that seems persistent, doesn't go away, and isn't well explained by anything else. Some patients just have this unnecessary urge to have a bowel movement. And again, these issues are not just like a one-time thing, but maybe it's a little bit more prolonged. But things that we should pay attention to, or prolonged constipation or diarrhea. And then when we do actually lose some blood in the stool, people have signs and symptoms of anemia, which might be some tiredness or weakness past your baseline, or even shortness of breath. And then probably most commonly, most people don't have any symptoms at all. So I think that, you know, that leads us into kind of screening and other things of how we can actually prevent colon and rectal cancer. So who gets colorectal cancer? Most commonly, it's based on age. So as you get older, you're more and more likely to develop colorectal cancer. However, I think it is important to see here that even in this younger age group, so traditionally we recommended screening for colorectal cancer around age 50, but there's definitely an increasing incidence of cases in patients who are much younger than that. And so the guidelines have changed to actually begin screening at age 45. And so actually men and women both get colorectal cancer. It's more common in men. However, women tend to live a little bit longer. And so the overall incidence for men and women in the long term is actually pretty similar. Any ethnic or race group, so non-Hispanic Blacks, American Indians, Alaskan Natives, non-Hispanic whites, Hispanic Latinos, and Asian and Pacific Islanders are less common to develop colorectal cancer. And then non-Hispanic Blacks, it's actually a little bit more common. And the reasons for this are complex, and I kind of discuss it briefly on the next slide. I also want to mention some other people who are at higher risk than average. And again, it's based on age, if you have a family history, if you have a chronic GI medical condition, such as inflammatory bowel disease. And then rarely, maybe in 5% of the cases, some people have hereditary cancer syndromes within their family, and then type 2 diabetes. So with regards to some of the higher risk races and ethnicities, then I really want to point out that here you can kind of see in the light green that the mortality rate is higher for non-Hispanic Blacks. It's higher for American Indian and Alaskan Natives compared to, say, non-Hispanic whites. And so, they've done a lot of kind of population-based studies to kind of try to look and see and understand why, and can statistically try to control for different factors. But it seems like it potentially comes down to access to care as well as screening. And then maybe other risk factors that are potentially lifestyle related, smoking and being overweight. And then non-Hispanic Black individuals, though, have a higher mortality. And I think it's because they're less likely to get timely follow-up. And as well as biologically, there may be a slight difference. There may be more tumors in the ascending colon, which present a little bit differently. They're not as obvious. You oftentimes don't have any symptoms at all. And may also be a little bit harder to screen for and detect. So screening for colon cancer saves lives. And I think that this is the kind of key take-home point that I want to point out. Colorectal cancer is the third most common cancer in the United States. There's probably about 150,000 cases per year. And so being able to really diagnose it at an early stage leads to high survival rates. So many patients can be cured if we can find it early. However, statistically, a lot of times we're just not finding it early enough. And we have great tests for it, which I'll cover on a subsequent slide. And so I think key things to know here, though, it tends to be increasing in incidence in patients who are under 50. And this is a trend that we've seen now for many, many, many years. And it's concerning. And I think the reasons for that are not totally clear, but again, why the screening age has been lowered. And also just a note about COVID-19. I think with everybody here, they've seen that, especially at the initial phases of the pandemic, with the recommendation to kind of stop any kind of non-urgent or emergent procedures, then there was a huge drop in colonoscopies as well as primary care visits and other kind of routine kind of cancer surveillance and health maintenance type visits. And so that's led to an estimated kind of 18,000 missed or delayed diagnoses of colorectal cancer throughout the 2020. And so I think we have yet to see the long-term impact of it, but I think that there's still an opportunity if we can get people screened, and I think people for sure are coming back in to see their doctors again, but encouraging friends and family members who we know to try to just get back in to see their doctor and kind of go back on the health maintenance routine, then we can kind of recover from some of this. And the added part here is that there's been a lot of, now that we know more about the pandemic, I consider it very safe. There's plenty of processes in place to prevent the spread of COVID. And so, if people are afraid of contracting COVID through procedures and things like that, at least rest assured that there's a lot of policies and procedures in place to really minimize that now. So briefly, there's many different screening tests They're divided into stool-based tests, as well as those where we're visually taking a look at what's inside the colon. The key thing here is at the latest, you should start at the age of 45. So there's a lot of reasons potentially to start earlier than that. So for example, for myself, I had some symptoms once before. And so I'm under the age of 45, and I opted then to see my doctor and then get a colonoscopy. So the stool-based tests are kind of what they sound like. So on this next slide here, you basically get a kit, and you can kind of lay out a piece of paper, have a bowel movement, have the stool sample on top of there, take a quick sample of it, put it in the tube, and then put it back in the container, and then kind of follow the instructions to send it back. And so what this test is really looking for is to detect blood in the stool, which can be either due to tumors or just polyps or a variety of different reasons. But if we see something like that, then our next recommended step would be to get a colonoscopy, so we could actually visualize what's there and either biopsy or basically take care of it that way. And usually you would do this once a year. There is another stool test that looks at certain DNA changes. It's called Cologuard. And so this one is a similar process, but you can, because it's looking at DNA changes, it's a little bit more sensitive. You don't have to do it annually. It's generally done every 3 years. Both of these tests, though, if they come back abnormal, we would recommend getting a colonoscopy. And so a colonoscopy is just, I have another slide on it right here, but basically it's just, you'll go through a bowel preparation to kind of clear out the colon and the rectum, so that we can actually see things like this, like polyps. And then this is the colonoscope. It has a little camera here. It has a tube to kind of spray water and clean things out, and a light. And then a little port here so that if a polyp like this is seen, then it can be clipped and then taken back and then sent to be analyzed, so that we know if it's either a benign or a non-malignant polyp, or it's something that looks like it's becoming an invasive cancer, or it is cancer itself. And I think the key thing I want to point out here is that a colonoscopy can screen for cancer as well as prevent it. So these polyps sometimes develop into cancer. And so by doing routine recommended colonoscopies, when these polyps are seen and they're clipped and removed, well, they don't become cancer anymore. And so it's an effective kind of 2-for-1, screening and prevention. And then there are modifiable risk factors. And these, it's not quite clear if any of these things directly lead to the development of colon and rectal cancer, but it seems to be associated. So when I think we get the opportunity, and we're all to make changes in our lives, then I would just kind of generally encourage a healthy diet, one with a little bit less red meat, processed meats, having just a healthy weight. It seems to, again, be associated with being overweight or very overweight. Maintaining some level of physical activity I think is great, again, associated with cancer. And then trying to avoid things like carcinogens, like smoking, and then heavy alcohol use. And then in some patients with also a concomitant cardiovascular risk, then they would consider doing a low-dose aspirin. So low-dose aspirin for patients who also have another risk factor for something else, then this can be associated with decreased rates of colorectal cancer. And then just my final slide on future directions. So I kind of mentioned for screening purposes, there was a stool-based test, the colonoscopy for visualization, and then we are working on blood-based testing and screening, where we can have new techniques to look at cancer DNA in the blood that's sometimes shed by cancers. And so this kind of early study showed that in patients without any symptoms at all, this blood test was able to detect cancer in 90% of them. And if you did have some symptoms, 96% of patients, that we were able to find an abnormal test on this blood test. And so there's a prospective kind of clinical trial ongoing to kind of validate and better understand the utility of a blood test. Okay, so please get your colorectal cancer screening and encourage everybody to do so as well. It's and hopefully we can kind of get back from kind of the setback that COVID-19 was.
Dr. Vu, that was an excellent presentation, very thorough, very effective. I will say that I had delayed in some ways having a colonoscopy. I was at the age where I should be getting it, finally got one. And the actual procedure was a pretty insignificant experience. And yet I would say maybe psychologically there was a little tentativeness, a little anxiety, because it's that unknown. Will they find something? And I wonder how often that kind of dynamic comes to play in terms of people pushing off those screenings. That's why this is so important to provide that information. And having had the experience of a colonoscopy now, I have no issues with getting that information. I definitely understand the merits and the value of it. But I wonder if there is that hesitancy in a more broad way.
Absolutely. I think it's really common for people to feel that way. And also having had it myself, I can also I feel similarly to you. I've spoken to a lot of patients as well, and they also have put it off for a while. And then once they finally got it, then they're like, you know what, really, it was not that bad at all. And given kind of either that what they found afterwards, they were so grateful to have had the colonoscopy, and then they became advocates themselves to tell other people that, it's really not so bad. It sounds really scary at first, but I think the bowel preparations have gotten a lot better. And so, it doesn't take as much time. And overall, it's just not as uncomfortable or kind of bothersome of an event to just get a nice cleaning out, so to speak, of your colon.
Exactly.
And the procedure itself is like maybe 10 minutes long.
Yeah, and I would say it's a very restful experience for really, because you're partially under or whatnot, and so it's in some ways a very benign experience. One thing that's fascinating to me, and it really shouldn't be, that one slide that you looked at predispositions and risk factors, it really comes down to living a healthy life, eating, active, and it's not surprising that it comes back to that. It makes complete sense. But as I think about your earlier statistic of how there's a greater incidence of colorectal cancer with those under 50, and I wonder how much of that's lifestyle. Obviously, we're testing at a greater rate, so maybe we're seeing more because we're testing more. But I have to believe it's definitely a factor of the lifestyle. Just looking at how we've become more inactive, food isn't as healthy as it used to be 20 years ago. And so it was fascinating to me. If we live a healthy, balanced, active life, eat well, we're usually in pretty good standing. Obviously, genes come to play, but.
Yeah, you're right. And I think the only thing I want to add about that is just that it's hard to predict. These are all kind of risk factors. And yes, I'd say, if we had the choice, do your best to live kind of an overall healthy life. But some of my patients still, they've done everything they possibly could, and it still happens, and vice versa. And so kind of just do what you can. And if you have symptoms, and if you're at that screening age, or if you have a family risk factor, then the best thing to do is talk to your doctor about it. Think about either doing a stool-based screening test or just get the colonoscopy, which can even be preventative at the same time.
Great. The last question that I have for you is that I just look at that statistic on the incidence of the lower socioeconomic and the higher rates of colorectal cancer, and how much of that obviously is the health inequalities and getting information to people. And I don't know if you can speak to in some way what we're doing to make sure we're getting that information and providing greater access.
And I think it's, for us as healthcare providers, we want to just get the word out and try to reach people and talk to people so that they're aware. And again, by speaking directly to the community, hopefully people who are listening can encourage their friends and family members as well. And that's what I'd say about that. I think that just having access to care and is going to be a big factor in helping with that.
Excellent. Dr. Vu, thank you very much. If you'll stick around for just a little bit more. And finally, our final guest, Dr. Angelique Richardson. Dr. Richardson, welcome. Thank you for being with us. I know you've been busy up until the moment we started our webinar with being in the clinic, so I appreciate you making the time to join us.
Thank you. I'm going to go ahead and share my screen.
Excellent. And you're going to be speaking to breast cancer awareness. Thank you.
Yes. Are you seeing that my screen okay?
Yes, I am. Thank you.
Okay, great. Thank you. So I am going to be speaking today on breast cancer awareness. I'm a breast medical oncologist here at UCSD. So I'm going to start with a few breast cancer facts. Breast cancer happens when a normal breast cell grows out of control, and it usually forms a mass. And this may be palpated, or you may feel it yourself and go in to seek care from a healthcare provider, or you can have it found on a routine health exam by a medical provider. Also, this can be found on mammogram. So there are two main types of breast cancer. The most common type is found in the duct of the breast. So you'll see the pictures here on the side. This long tube structure, those are the ducts. And then there's the round things at the end. Those are lobes or lobules. And so if the cancer is found in the duct, then it is invasive ductal cancer. If it's found in the lobe or the lobule, that's invasive lobular cancer. Invasive ductal is about 80–85% of breast cancers. Invasive lobular is 10–15%. Then there are also other less common types. So breast cancer is a very common cancer type. In 2022, it's estimated that greater than 285,000 people will be newly diagnosed with invasive breast cancer. So that comes down to about 1 in every 8 women. And this is also a disease that can be found in men. Approximately 2,700 men will also be diagnosed with breast cancer. And this is the second leading cause of cancer death in women behind lung cancer. So although the death rates of breast cancer have decreased by an estimated 40%, this is due to early detection and increased awareness and better treatments. And the good news is that now there is more than 3.5 million breast cancer survivors in the US. So we're going to talk about some signs and symptoms of breast cancer. And previously, you probably heard that you would check your breast every month, and you make sure you check in the shower. Now the recommendations are more of along the lines of a breast awareness. So that does include routinely checking your breasts to know how they normally feel or how they look normally. And regular screening is important. So we're going to talk about mammograms and the importance of regular screening with mammograms. But also remember that breast awareness is important because sometimes cancers are detected in between mammograms. So it's very important to also have that awareness. So some common symptoms are a breast lump or mass. So you may or may not feel it, but it can be seen on mammogram. Typically, it is a painless, hard, and irregular mass. But it's very important to remember that breast cancers can be tender, soft, and round. So I've heard women come in and say, well, it was painful. I didn't think it was breast cancer, so I thought it was something else that was probably benign. And many times it can be something that's not cancer, such as a cyst. But remember that breast cancers can also be painful. So you want to get it checked. If you feel something in your breast that feels abnormal, always get it checked. These are some of the signs and symptoms that you would look for. So if you look at the picture here, nipple retraction or a nipple discharge. So if you have a bloody or a liquid, any type of liquid discharge from one nipple, you want to get that checked out. Also, you can have changes in the skin texture, or what we call peau d'orange. It looks like an orange skin. You can have erythema or redness. The redness can be on the breast, or it can be under the arm. Nipple itching and scaling. Any type of skin ulcer. And again, any dimpling. You can also have swelling under the arm. There are lymph nodes under the arm of the breast that can be swollen, or here just under the collarbone or near the collarbone. So any sudden change in shape or size, you want to get that checked out. And sometimes it can be a lump in the skin, but also it can sometimes be a change in the thickness. So how is breast cancer found? I talked a little bit about breast awareness. So just knowing how your breasts normally look or feel, but then others are found on screening mammograms. So there are different screening mammogram guidelines. I put a few of them here. Some of the more commonly known ones are with the American Cancer Society. Their guidelines are for all women, yearly mammograms starting at age 45, and that can be changed to every other year at age 55. But for the United States Preventative Services Task Force, and the risk is for an average risk woman, the age starting at mammogram at age 50 to 74 every 2 years. And if you are below that age, so if you are 40 to 49, then you should talk to your doctor, and that is a shared decision. But many of the cancer societies, including the Cancer Center here at UCSD, we recommend that all women 40 and older who are average risk start yearly screening mammograms. So this is a recommendation I give to my patients. Yearly mammograms if you're older than 40. That's if you're average risk. If you're high risk, then your screening could actually start before age 40. And women are high risk due to things such as genetics. If you have a BRCA mutation is a genetic mutation that you inherit from your parents, and that will put you at a higher risk of developing breast cancer in your lifetime. Or if you have family history, a significant family history, multiple family members with breast or ovarian cancer. So those recommendations for screening are based on history and your estimated risk. So at UCSD, we have the traditional 2D mammograms, but also we have what's known as a 3D mammogram. This is a digital breast tomosynthesis. And this machine is, it helps decrease what we call callback rates. So callback is when something is found that's abnormal on your mammogram, then you are called back in to get additional testing and workup. So because the way that this machine works, it's like flipping through the page of a book. It gets much thinner slices of the breast. So we're able to get clearer pictures. And then also we're able to diagnose breast cancer when it's a lot smaller. The benefit is seen in younger women who have more dense breasts. And because it's a newer technique, it also can minimize the radiation dose. So I just wanted to cover some of the myths that I've heard with mammograms over the years. It's not all inclusive, but this is some of them. Some women have told me they don't want to get a mammogram because radiation from the mammogram could cause cancer. So mammograms use very low doses of radiation, and the risk of harm from this dose is extremely low. So that should not be a reason for you to be concerned about getting a mammogram. Another myth is mammogram can cause breast cancer to spread. So that is not true as well. It does not cause the cancer to spread from getting a mammogram. And then some people are just afraid. They're afraid to find the cancer. They don't know. They don't want to know because they're afraid of what that could mean. But finding a cancer early can save your life. So it's very important to know, and to know as soon as possible if you have a breast cancer. Another concern is they cost too much, but most insurances cover the cost, and they are also free clinics and screening programs. If you you feel you don't have time to get a mammogram, digital mammograms could take approximately 30 minutes. And at UCSD, they have weekend and evening hours. So you can get them, usually you can find the time that will fit your schedule. And then other people are a little bit concerned about it being painful. But the 3D mammograms, they have the new design, and the fact that it's a faster exam time, the discomfort is often minimized. So most people come back and say, oh, it wasn't as bad as I thought it was going to be. So decision to get a mammogram, when to start screening, has to be shared with you and your healthcare provider. Again, my recommendations are if you're older than 40 and you're average risk, then you should start getting your yearly mammograms. But you need to understand your risk limitations and the benefits of screening. And so this must be personalized for you because, as I mentioned, family history or any type of mutations, or if you're of Ashkenazi Jewish descent, you may be at a higher risk. And so that those recommendations for you may change. So some factors that increase breast cancer risk, being older, just as with many cancers, being postmenopausal, association with a higher BMI. The thought is here that your fat converts, your body fat, there's conversions into estrogen. And so that's increased risk of having breast cancer. Also, your length of time exposed to estrogen. So if you use hormones like OCP, oral contraceptives, or hormone therapy, if you had an early age of starting your periods or later age of menopause, you've never had children, or if you were older when you had your first pregnancy, all of these things can be associated with an increased risk. So there's this thing that some of you on the line may remember Angelina Jolie, this thing that was called the Angelina effect. And she, what this is referring to is the increase in BRCA genetic testing, or BRCA, breast cancer gene testing, after Angelina Jolie came out and said that she did have this mutation, and she made the decision to go ahead and do some preventative treatments regarding this. And so BRCA is one of the genetic mutations, 1 and 2, but there are also others that can put you at increased risk. Also, alcohol consumption. So you want to, you have moderate use of alcohol, smoking, or exposure to radiation at a very young age, a particular type of radiation that's usually given for lymphoma. All of these can increase your risk. So some things that you can do to prevent, a lot of people usually ask me about preventative measures. So one of them is if you've given birth, breastfeeding is a preventative measure. Also just remaining physically active. There are many studies regarding diet that are inconclusive that I don't really get into here, but overall, in general, a good, healthy diet is what we recommend. Good, healthy, well-balanced diet. And exercise, if there's moderate to vigorous exercise greater than 3 hours a week, it's been shown in some studies to lower your breast cancer risk 30 to 40%. And the higher the activity level, the lower the risk. So there are some breast cancer disparities that are well known. It's well known that Black women are less likely to be diagnosed with breast cancer, but they have worse outcomes when they are diagnosed. And so they have fewer Black women are diagnosed, but they're more likely to actually die from the disease once they're diagnosed. They have a 40% higher risk. And so research shows that this is multifactorial, and it has to do with things such as their more advanced stage of disease at the time of when they come into the clinic. There's a higher chance of them having a very aggressive type of breast cancer, which is called triple negative breast cancer. There's also a higher percentage of having a BRCA mutation. But studies show that there's very little difference between outcomes between Black and white patients when they're diagnosed at an early stage. So that dramatic difference is really at the later or more advanced stage of disease, which points back to the importance of getting the screening to detect cancer at an earlier age. And so this has worsened since the pandemic, the COVID-19 pandemic, the disparities. And part of this is because several studies have shown a decrease in routine cancer screenings, including mammograms. And as Dr. Vu mentioned, it's because these sort of screenings were put on hold, elective procedures were put on hold in the beginning of the pandemic due to public and healthcare concerns for the spread of COVID-19. Also, there was limited personnel and resources. There were some studies that showed that more than 1/3 of adults miss routine preventative screenings. And some studies report an initial decline of 86 to 94% in preventative screenings. And this impact was greatest in our underserved patients or in our Black patient population. And so this is due to social determinants such as lack of access to healthcare and also this breast cancer screening disparity. So another thing that we know is that Black women are less likely to have the digital breast tomosynthesis or 3D mammogram. And as I discussed earlier, this mammogram is known to detect cancer at an earlier stage. There was a study that just that was just published by one of our own trainees here, Dr. Jade Zhao. And the study was a comparison of early and late stage breast cancer and colorectal cancer during versus before the COVID-19 pandemic. And what she showed was that she evaluated the stage of disease at initial presentation to clinic in 2019 and 2020. So she showed there was a decrease in early stage in the stage 1 and an increase in late stage. So there was a decrease in people coming in at the very, very earliest stage. And there was an increase of people coming in with breast cancer that had already unfortunately spread. And that was a stage that's no longer curable. So it is important to get your routine cancer screenings as recommended. Cancers that are found at an earlier stage are more easily cured, and it saves lives. And I'll just briefly, in the last couple of slides, what happens when you're diagnosed with breast cancer. If you come to UCSD, it's an NCI designated comprehensive cancer center. You have a dedicated breast specialist who focus on your care. And we have a team made up of multiple specialists who work together in a patient-centered manner. So these are some of the resources, and thank you for listening.
Dr. Richardson, excellent presentation, powerful information. That last study that you noted in terms of up to a third of screenings being missed, that's not the kind of thing that you can catch up on. It actually just creates a greater imperative for us now to get current with our screenings. Dr. Mayadev, I know you may have to hop off. I appreciate you being with us. We're just going to spend another minute or two. Dr. Richardson, I really appreciate the concept of breast awareness. That's a new concept for me. I was familiar more with mammograms. And so I appreciate kind of broadening the context in terms of our own screenings and awareness and how we can empower our health. So I greatly appreciate that. Also, it was it was helpful for me to hear, when I think of breast cancer, I don't necessarily think of checking your neck and armpit and the lymph nodes. So that's very important as well. You did a fantastic job of really demystifying concerns and creating the path, a very open door to get your screening and therefore be able to be empowered with health information. So I appreciate that. In closing, what I'd like to do is offer, there was a question that came in earlier from our audience related to stress. We're discussing more of a medical model. We looked at risk factors, but in the whole person wellness focus, I just wonder if either of you can speak to just the incidence of stress and how that impacts cancer rates.
Yeah, I can start. So one thing that we do know about stress is that it affects our overall health. There's various studies showing that, including how it can affect our immune system. And we know that when our immune system is not optimized, then that can also lead to an increased risk of cancer. So I definitely tell patients that stress definitely does not help. And so for a whole list of diseases. So we definitely need to, I always encourage my patients to manage stress for as a preventative measure.
Yeah, excellent point. I just look at the time that we've come through these last 2 years with the pandemic and a lot of unknowns and uncertainties and emergent issues and the challenges with that. So attending to our well-being and guarding off stress and having tools to take on stress are critically important. Peter or Dr. Vu, anything you wanted to say?
Yeah, no, I would agree. And I think that there's always the stress, and each of us maybe copes with that stress a little bit differently. For some people, maybe it changes their dietary habits. It could, for some people, it increases their physical activity, and for others, it may decrease it. And so I think it's overall, it's very hard to pinpoint, one specific risk factor that then leads to cancer. However, I do totally believe in the sense that by maintaining an overall sense of well-being, and that's mental, physical, in many different ways for different people, having that sort of balance, and you can almost feel it inside, is helpful. not harmful. And I think that that's the best that we can do, in addition to essentially getting all of our cancer screenings and paying attention to our body.
Great. Another quick hit, if I could. I just think of technology, and I wonder about digital adoption by the medical industry, medical profession, and the tools and resources that that are coming online to support screenings and cancer prevention. And if there's anything you can speak to in that way.
Yeah, so, I think what's changed during the pandemic for us from a digital technology perspective is that maybe sometimes on certain days, either 50% of my clinic is completely virtual. And so I think that's helped with patient access a lot in those who are able to have the technology and maybe not even have the language barrier, so to speak, to be able to kind of do a virtual visit with their physician. But I think it's a powerful kind of new way that we're delivering kind of medical care, and at least we can kind of provide our thoughts and about any symptoms you're having, kind of provide any advice, and then still get those tests ordered and get things done without having to meet face to face.
Right. The last thing I will pose to the two of you, if you will, is just looking at what might be the next steps in your particular area of cancer prevention as an industry. What's on the horizon in terms of, we're making significant inroads, having great impact. What might be next?
Well, I kind of mentioned it in one of my slides. It's really, we have this sequencing technology now, and it's getting better and better. So being able to detect using very small amounts of, say, blood, to really detect cancer with just a blood test. So in some ways you might think, a lot of times your physician may order just routine labs once a year or something like that. And they may then be able to just add on this one test. It's like another tube of blood or something like that as a potential way to screen for not just colorectal cancers, but I think they're working on applying that to different types of cancers as well.
Wonderful.
Yeah.
Well, please, Dr. Richardson.
Oh, no, I was going to say, I agree with that. And that's definitely a platform that they're trying to look at, including breast cancer in that as part of a screening with just a blood test with your PCP. And so I know it's down the road, but I think it's exciting that they're looking at that.
So thank you. I just want to say thank you for the important work that you're doing in terms of providing for the health of our community. Greatly appreciate your work. Thank you for joining us today and bringing to the Y and our and to the public all this important information, and greatly appreciate everything you do. So thank you for being with us today.
Thank you as well.
Thank you. And for those that joined us, please be well until the next time that we're together. Thank you very much.